everyone, my name is Dr. Carratt and I am a cancer biologist in Portland, Oregon. During this talk today, I'm going to cover the epidemiology and public health aspects of the current coronavirus pandemic. I'll talk a little bit about the spread of COVID-19, how it compares to other diseases, and how tests for COVID-19 are conducted. And I'll start with a brief introduction and a disclaimer. First, I want to say I'm very excited to have this opportunity to record a presentation for you. I graduated from Murphy a little over 10 years ago, and I took several of Dr. Wallenstein's classes in high school. I have a Bachelor of Science in Biology and a minor in Chemistry from Loyola Marymount University, and I received my doctorate in pharmacology and toxicology from UC Davis. I spent 4 years researching respiratory diseases and lung toxicology at the University of California, Davis, and I've been a postdoctoral scientist researching genomics of leukemia and cancer biology for the past 2.5 years. If you have questions about this talk or about a career in science, feel free to reach out to me via email, and that's listed at the bottom of the screen, and it'll be shown again at the end of the talk. Finally, I do want to give a disclaimer because of the medical nature of the things I'm going to cover in this lecture, which is that I am a scientist and not a practicing physician. I don't see patients, so the information in this presentation has been compiled from the existing scientific literature that was available at the beginning of April, also from my personal experience working at a research hospital. With that said, let's begin this talk on COVID-19 epidemiology and public health. To start with, what does epidemiology mean? When you break it down into its roots, epidemiology is really simple. It's the study of people. In the context of medicine, epidemiology deals with the instance, distribution, and possible control of diseases and other factors relating to health. In other words, epidemiology is the study of the patterns of health and disease. The goal of understanding epidemiology is to reduce the risk and occurrence of negative health outcomes. When we think about COVID-19 epidemiology, we're asking, what is it? What is this disease? How does it spread around the world, and how does it spread between people? Are there similar diseases to COVID-19 that we've experienced in the past? We're also considering measures to control the pandemic and trying to understand how we can mitigate negative health outcomes from this disease. By now, I imagine we're all fairly familiar with the symptoms of COVID-19, but just to back it up and get us all on the same page, the symptoms are cough, fever, difficulty breathing, and in severe cases, patients will get fluid in their air spaces and develop pneumonia. Transmission of SARS-CoV-2 is primarily spread through respiratory droplets. Respiratory droplets are generated when you cough, sneeze, talk, and they travel short distances through the air, usually less than 6 feet, and they can both directly and indirectly infect other people. Directly is when these particles travel through the air and reach your susceptible mucosal membranes, your eyes, your nose, and your mouth. Transmission can also occur indirectly through touching contaminated surfaces and then allowing your hands to touch your face. With epidemiology being the study of disease and the intention of epidemiology being to prevent negative health outcomes, it's important to understand how the current disease we're dealing with, how COVID-19 is similar to diseases that we've seen in the past. And the first place to start is that coronavirus is actually the name of a family of genes, not just the specific virus that we're dealing with today. And the family name for this virus is Coronaviridae. Most coronaviruses that infect humans, that are pathogenic to humans, are actually fairly mild in terms of clinical symptoms. The two notable exceptions to this were the SARS and MERS epidemics that occurred, and both of these diseases, when they broke out, all the cases required hospitalization. SARS is severe acute respiratory syndrome. When the outbreak happened in 2002, it caused 8,000 infections across 37 countries and resulted in 774 deaths. MERS, Middle East Respiratory Syndrome, had an outbreak in 2012, and this was first detected in Saudi Arabia, hence the name. It ultimately ended up causing 2,500 laboratory-confirmed cases of infection with just over 850 fatalities. When we start putting these diseases side by side into a chart to compare how similar they are, we can see that the three coronaviruses listed have very different rates of fatality, different incubation times, and their hospital rate really varies. We've included the flu here as a comparison so that you can see how that compares to coronaviruses, and you can see that it has a much lower fatality rate than any of these three coronaviruses, and the incubation time is generally shorter. Hospitalization rate is also lower for the flu. Take a look at the Arnott number, the basic reproductive number at the top of this chart. For the flu, it's 1.3. For COVID-19, it's between 2 and 2.5. SARS is 3. MERS is 0.3 to 0.8. What does this mean? Well, this is a measure of just how contagious each of these diseases is. This graphic shows us a scale of R0 values for a variety of infectious illnesses. At the top, we've got the lowest R0 with MERS, and at the bottom, we have measles, which has the highest R0 of 9. What does this mean? R0 is a measure of if one person walks into a community where no one has immunity to the disease, how many people is that one person going to affect? For the seasonal flu, if one person walks into a room where nobody's had a flu shot, nobody has immunity, they're expected to infect one other person. With COVID-19, if a person with COVID-19 walks into a community with no immunity, like we have right now, they're expected to infect 2.2 people. Measles is the most infectious of any of these diseases listed. If somebody with measles walks into a community where no one has received their immunizations, they are going to infect 9 different people. And this really underscores the importance of vaccines and of building immunity in a whole population of people. So here's another way of looking at that same information. You've got one contagious individual in a community. That first individual is going to affect 2 other individuals. The second 2 individuals that are infected will proceed to infect 4 other people. As this scales up over time, you can see for both the low estimate and the high estimate, this becomes an exponential curve of infection. When a new disease emerges, there is no immunity to it. There are no vaccines in the population, and there's nothing your body can do against a disease it's never seen before. At the onset of infection, the disease passes freely among the individuals in a community, and ultimately the only 2 outcomes that can come from community-wide spread of disease is that you acquire immunity through surviving the infection or you pass away from the infection. And ultimately, this is the worst outcome of a new disease emerging. This is what happens when immunization can't be achieved, when we can't develop a vaccine, and this is what happens when we don't engage in measures like social distancing. When we engage in preventative measures like social distancing, what happens is that we isolate not only the affected individuals, but we isolate the healthy individuals. And even with the majority of the community following these principles, we're able to reduce the spread of infection and slow the rate of infection. By the time the disease has passed through the affected members of the community, there have been a number of healthy individuals that have successfully stayed isolated through the experience. And therefore, even without the development of an immunization for the disease, you can still get better outcomes for the community. In the best case scenario, you acquire a vaccine. There's a number of efforts working towards developing a vaccine for COVID-19, and I'm very optimistic about that, but we'll just have to see how it goes. When you're able to acquire a vaccine, the infection can't pass freely among individuals. Individuals are protected from the spread of disease by those that are infected. Only unvaccinated individuals or individuals who are not properly isolated from society will become infected. Those infected individuals will then either pass away or acquire immunity themselves through experiencing the infection. Ultimately, developing a vaccine is going to have the best outcome on survival, but the practices of social distancing are still extremely important for slowing the spread of disease. This graphic is showing the early spread of COVID-19 through the beginning of January to the end of February. This disease began as a pneumonia of unknown etiology or unknown cause that was detected in Wuhan City in the Hubei province of China. In the first month of January where this disease was known, it had 278 cases in China, just 2 cases in Thailand, 1 case in Japan, and 1 case in the Republic of Korea. Unfortunately, this disease has continued to spread to become a global issue, and on the next slide, I'm going to show you where this disease is at today. This is a map. It's a wonderful resource from Johns Hopkins University of Medicine that shows the current state of the COVID-19 pandemic. Tragically, there are more than 1 million confirmed cases of COVID-19 across the world and 72,600 deaths. If you switch the map, you can see the number of active cases of COVID-19. We can use this map to really understand what the current state of things is across the world and in our own country. If you zoom in on the United States and on North America generally, you can use this as a tool to view different cities. We hear a lot on the news about hotspots of disease infection, including New York. If we're to zoom in on New York here, you can actually click on New York City and you can see that they currently have 69,000 existing cases of coronavirus. They've had 72,000 total, and they've currently, as of the time of this video, experienced 3,000 deaths from this terrible disease. Compare that to King County, Washington, which had about 2,500 cases of disease, and Snohomish County, Washington, which had 1,500. The deaths in Snohomish County are significantly lower than what we're seeing in New York with 48, but again, to avoid situations like what's happening in New York from happening over here in the Pacific Northwest, it's going to be extremely important to keep up with these social distancing and hygiene measures and to really be careful in our actions and be socially responsible. For the last part of this talk, I wanted to share a little bit about how hospitals are testing COVID-19 patients. I work at Oregon Health and Science University, which is a research hospital, and they are currently accepting and treating COVID-19 patients. While I don't see patients myself, my research does still require me to be at the campus part-time, so I'm deeply invested in the success of our testing efforts. I'm also trained to do this testing should the need arise. If you think back to the beginning of this pandemic, the news was constantly talking about how there was a shortage of coronavirus tests. Because of this shortage, a procedure for testing emerged where the first step was to rule out other causes of disease. This allowed them to conserve tests for the people who most probably had COVID-19. The most common test that was used to rule out other causes of disease was a test for influenza, for the flu. This is because many of the symptoms of COVID-19 and influenza overlap. Think about fever, fatigue, cough, and sometimes nausea. After a patient's test for influenza came back negative, then a patient could be tested for coronavirus. At the beginning of all this, the hospital was only running a handful of tests a day, but now we've actually scaled that up quite a bit. OHSU constructed a brand new facility specifically to run COVID-19 tests, and they have screened approximately 1,300 patients and staff members to date with 52 positive tests. The type of screening that is done here at OHSU is traditional RT-PCR. This is a test that looks for the presence of viral genetic material. This test traditionally takes anywhere from a few hours to a few days, depending on an institution's resources. Because these tests are labor and time intensive, they are often run by staff scientists whose sole job is to analyze these samples. Now, recently, a couple of companies have come out with new point-of-care tests. These tests also look for viral genetic material in a patient sample, but they don't require specialized training. They can be done rapidly in the hospital, allowing for doctors to proceed much more quickly with quarantine measures and treatments. The COVID-19 RT-PCR test is a reverse transcription polymerase chain reaction test to determine if SARS-CoV-2 is present in respiratory specimens. In other words, it's a test to see if genetic material from the coronavirus is present in the patient's airways. Respiratory specimens are most frequently collected from patients in the form of nasopharyngeal or oropharyngeal swabs. What we're seeing here is a diagram of nasopharyngeal swab, in which a long, sterile, cotton-tipped swab is inserted through a nostril to collect a sample from the nasopharynx, which is the upper part of the throat behind the nose. To determine if there is viral genetic material in our sample, we take those cells from the nasopharyngeal swab and we isolate the RNA from those cells. Now, all human cells are going to have RNA in them, but the ones that contain the virus will also have viral RNA. To detect and quantify the amount of viral RNA, we engage in this process called polymerase chain reaction, or PCR. PCR seeks to first transcribe this RNA to cDNA and then amplify these DNA sequences that contain the virus by labeling them and quantifying the amplification. To test for the presence of SARS-CoV-2, the first step again is to take that nasopharyngeal swab and to isolate RNA. All human cells are going to have RNA in them because our cells are continually transcribing messenger RNA to carry out biological functions. Any RNA that's isolated from a non-infected patient will only contain normal human RNA. RNA from a COVID-19 patient will contain a mix of viral and human RNA. We want a way to just identify the genetic material that belongs to the virus, and the PCR component of this reaction allows us to do this, though it only works with DNA. So, the next step is to use reverse transcription, RT, to make a DNA copy of the isolated RNA. Then, we can use molecular tools to label and amplify the sections of DNA that match the known COVID-19 viral sequence. We read the output of the amplification reaction as a measure of fluorescent signal. The amplification process happens over a number of cycles in which copies of fluorescently labeled viral DNA are produced. The increasing intensity of this fluorescent signal that happens as the amplification continues can be measured on a graph like this one. And here we can clearly see how a positive sample, as seen in the blue line, increases in signal intensity as the cycles continue and as the viral DNA is copied. This positive sample can be clearly separated from a negative unamplified sample. The PCR test identifies that the illness is caused by SARS-CoV-2. Additionally, there's a number of clinical tests that can be performed to assess the severity of a patient's symptoms. For respiratory symptoms, two of the more common tests are chest x-rays and CT scans. The severity of COVID-19 varies significantly from person to person. Chest CTs are used as an initial tool to assess disease severity, as well as to monitor the progression or resolution of disease. I'm going to show you some examples of CT scans because I spent 4 years studying respiratory diseases, and I think these are really interesting to look at. I think they also provide a different perspective for understanding how this disease manifests in patients. Okay, so on this slide, I'm showing you data from a study that came out earlier this year in radiology. The study looked at 121 patients with COVID-19 and tried to put together a summary for physicians about what kind of abnormalities you're seeing in CT scans. On the left, you've got a table summarizing the different types of abnormalities you see in the lungs. And on the right, I've tried to pull out a couple images so we can discuss what these actually look like in patients. At the top, we've got a phenomenon called ground glass opacities. The term ground glass opacity refers to these almost hazy spots in the lungs. They get their name because they almost look like sections of these lungs tissue are obscured by ground glass. These are caused by filling of the pulmonary air spaces with fluid, the collapse of air spaces, or both. The term bilateral just means these abnormalities are occurring in both sides of the lung. On the bottom, we see a lung CT scan from a patient that is affected both by ground glass opacities, which are bilateral, again, being on both sides of the lung. But in this lung CT scan, we also see consolidation, or consolidative opacities. This term consolidation refers to the filling of pulmonary air spaces with fluid or other products of inflammation. COVID-19, the virus causes an increase of inflammatory signaling in the lung tissue. And at the gas exchange surfaces of the lung, at the alveoli, this inflammatory signaling can cause leakage from the vascular system back into the lung. And the flow of fluid backwards from the blood into the lung creates these abnormalities we're seeing. The term peripheral means that we're seeing these on the edges of the lung tissue in this scan. So the cases I've just talked about are clearly people who felt the need to go to the hospitals because their symptoms were severe enough to need medical attention. But I'd like to devote a little bit of time to talking about something you've probably heard in the news, which is this idea that patients can have COVID-19 without symptoms, that you can be infectious without ever developing a fever or a cough. And I think it's critical to clarify a few key terms related to this, and then offer a little context for why you might be hearing about COVID-19 without symptoms. When people talk about asymptomatic coronavirus, they could actually be talking about one of three things. The first, they could be talking about truly asymptomatic disease. This is when you have coronavirus, there's detectable levels of the virus in your system, you are infectious to others, but you never have respiratory symptoms yourself. There was a case of this in Wuhan, China, where the disease first broke out, and there was a 20-year-old woman who infected 5 family members before they were able to trace the disease back to her. She never developed symptoms, but she was still infectious. The second thing we could be talking about when we hear asymptomatic infections is actually pre-symptomatic infections. It's this idea that you might not have symptoms during the time in which you're infected. The average symptom onset for coronavirus, for COVID-19 specifically, is 5 days. You can be sick for 1 to 14 days without developing symptoms and still be infectious with this disease. So, 2 different ways of not having symptoms and being infectious. The second one, pre-symptomatic, describes a state where you will eventually get symptoms. Finally, there's this idea that you can have very mild symptoms with coronavirus, something that you don't perceive as having disease. Even if you have mild symptoms that you might attribute to just being a little extra tired or allergies, this could still be the coronavirus, and especially in younger people, this is what we're seeing. With any of these cases, you have this idea that you might not realize you have symptoms at the time, but you could be infectious, which is why preventative measures end up being so important. This final graphic, it just drives home the point of it's better to be one step ahead than one step behind. Whether you're contagious with symptoms or contagious without symptoms, this idea of self-isolating and quarantining, while it's a little bit miserable to be home alone all the time, is extremely important. You can self-isolate if you know you're infected, but if you don't know you're infected, it's still important to isolate because you don't know if you have the disease. We're going to stop the spread of this infection by keeping people who may be sick away from others. With that, that's going to be the end of my talk for today. Thank you so much for letting me share this information with you. If you have any questions about the material or about careers in science generally, grad school, college, happy to answer questions via email, so feel free to reach out to me at any time. Thank you again.